thank you, Dr. Milla, for sharing this time with us. It's an honor to be sitting here discussing with you this morning at the 21st Annual CFRI Annual Education Conference. And Dr. Milla, I would love if you could introduce yourself to our community. And I have a few follow-up questions.
Sure. So I've been involved in CF for about 15 years or so. Early in my career, I was more interested in respiratory disease in babies, but then during fellowship, I became very interested in CF because I think, it's one of those fields where it kind of sucks you in, gets to your heart, and you get more than fully committed to it. And over the years, I've been both a researcher as well as a clinical provider. So what can I say? It's very close to my heart. And being here today and sharing all this information, which is becoming, overwhelming as the years go by as to all the progress being made. Again, coming and sharing it with the people that deal with it day by day is an opportunity that I won't miss for the world.
What sort of progress is being made for the treatment of B. cepacia? Can you comment on that?
That's an excellent question. B. cepacia is an interesting organism in that it's a bacteria that is very smart at making good room for itself and fighting other things in the environment that can create difficulty for it. So it's very good at fighting other bacteria, very good at fighting other microorganisms. And that makes it be not just very aggressive on its behavior, but also makes it be very resistant to antibiotics. It's what we call an intrinsically resistant organism, meaning it can use antibiotics as food. So one of the problems that we have in our patients is that, again, it's very aggressive. It can induce a lot of destructive changes in the lungs particularly. And most of the tools that we have to deal with it sometimes fall short of being able to do a full control of it. So I think, we need certainly better antibiotics, but we also need better tools that are going to help to start, prevent it from coming around. And I think there's a lot of effort being put when it comes to infection control guidelines and measures. But at the same time, I think, we need to sort of remember that we still have these patients out there that have become quite isolated because of that. And we need to develop tools to be able to treat with their disease. Because unfortunately, most of the studies that have been done so far tend to exclude patients who have these difficult infections, and cepacia is the prototype for it. But for example, we know that drugs like Astrionam, which is about to finally make it to the finish line when it comes to full approval, probably has some efficacy against cepacia, and it could be a good maintenance drug to bring to the armamentarium. We know that drugs like chronic azithromycin, for example, probably has the same effects, beneficial effects, that we could see in patients with Pseudomonas. So those studies, are ongoing. More studies need to be done. Again, applying the tools that we already have for the rest of the CF patients to these patients who typically haven't been studied that deep.
Of the therapies that are being developed to correct the faulty CFTR protein, which do you feel is the most promising?
Well, as the message I was trying to convey during my talk, is that we don't have one thing that we're going after. I think smartly enough, many years ago, the CF scientific community decided that, there were probably many different ways by which you could approach the CF defect, meaning either, correct the gene or correct the protein or find other alternative pathways that could lead to the correction of the basic defect. And the interesting thing is, each one of these approaches is yielding, and some are farther ahead than others, in the sense that we're very likely to have at least one drug on each of these categories that is going to help us control the disease. But what has also become apparent with all this work is that, there are a number of therapies that are going to benefit patients with certain types of CF, meaning certain types of gene mutations, as opposed to other patients. And that's the promise of genomic medicine that, we came to sort of foresee many years back. Depending on what specific defects you have in your body, there are certain treatments that are probably going to work better and give you some benefits as opposed to other treatments. And the best example is, for example, the data I show on the BX770 product from Vertex that, it was tested on people with the G551D mutation, not people with Delta 508 mutation. And it looks like, that's a drug that will work well for people who have mutations that work along the lines of the G551D. So it's going to become very important for the CF community at large to become more educated about these different mutations, and particularly for every patient to know what are their gene defects. Because again, as the years go by, we're going to get into a large array of different treatments that are probably going to work better for certain mutations as opposed to others.
Thank you. Yes. If I may ask, what research is being done to improve the outcomes and reduce complications for transplant patients?
Well, when it comes to the transplant arena, I think we're getting better in two fronts. One is in terms of immune suppression regimens. We have immune suppression regimens nowadays that can really help to control the body ability or even tendency to reject the graft, the transplanted organs, with a lower toxicity profile. We're having patients nowadays that can live full lives after the transplant without having to deal with toxicities and side effects from the therapies that we had in the early days of transplantation. So that's a very positive thing there. But the second thing is that I think, particularly for CF, specifically for CF, is that we're getting better at treating infections. Everything that we are learning from the CF clinic in general when it comes to chronic maintenance antibiotics and judicious use of antibiotics to control the Pseudomonas infection, we're bringing to a transplant arena so that we can get better control or prevention, particularly, of those infections coming and destroying the transplanted organ. So I think there's a fine balance between, the immune suppression and the infection prophylaxis and the infection treatment that are leading to better outcomes. Now, there are more and better immune suppressive drugs under trials, and there's also the possibility of developing some drugs like, or bringing back some old drugs like cyclosporine, for example, in different preparations. Aerosolization is something that has gotten a lot of buzzword because it's likely to give you very nice effect on the transplanted organ without all the systemic side effects and toxicities that systemic cyclosporine can have. So there's a lot of evolution when it comes to the CF lung transplant arena.
Thank you. And lastly, is there a correlation between baseline blood glucose and lung health? And if so, what causes that? Can it be remedied?
Yeah. So there's been a lot of work done when it comes to CF diabetes, which, when you hear about diabetes, people in the community at large, still think about, well, childhood diabetes, meaning you have no insulin production, your body loses the ability to make insulin. Or they think about adult diabetes, which is, people who are obese and have no ability to use the insulin right. Well, CF diabetes is a completely different entity. It's a little bit of a mix of both situations because people with CF over the years, and particularly when they get into their adult years, lose the ability to make insulin, but they still have some ability to make insulin, so it's not lost completely. But they also, as the years go by, develop a resistance to that insulin, meaning it doesn't work as well. And some of that is because of the recurrent and chronic infections. Infection is a thing that makes your body be more needy for insulin. So in CF patients, you have these two things evolving over time. Now, we have done many studies that have very clearly shown that this disruption in the insulin metabolism, and particularly in the glucose metabolism, is very tightly linked to detrimental changes in the pulmonary function, and is also very strongly influencing survival. So what we know is that we need to get better at detecting that glucose dysregulation early on because, again, it has a very strong influence on the progression of the disease. Now, we don't know exactly why it does it, but what we know is that if we intervene early with diabetes therapy, which for CF oftentimes is still going to mean insulin therapy, we can revert some of those detrimental changes.
Thank you very much, Dr. Milla, for your time. We're very grateful for your answers.